slides. All right. So last night, somebody asked me, so we're talking again tomorrow? Like, yeah. So what are you going to talk about? I said, ICP. He goes, after all that trauma, you do the ICP? Yeah, I thought about it, I felt bad for a minute, but actually, yeah, I'm going to talk about ICP. And the reason is something that Randy said yesterday. There's all this information, or all these trials, but when you think about what the BTF did with the guidelines, so there's only 4 high-level recommendations anyway. But the most helpful thing was the algorithm. And I'm going to talk about that algorithm, and I'm going to talk about algorithms that I've developed over the years and kind of end up with how it's changed now with the latest clinical trial information. And it's an algorithm that, is something that you can take and maybe use or modify and incorporate in your use. One thing I can tell you is that it's been shown that units that actually have algorithms, agreed upon plans, right, for how to approach ICP as it becomes more and more refractory, get better results than situations where everyone's trying to make it up on the fly every time anew. Or when all kinds of different people in the sandbox that we call the ICU have different ideas about how to do things. So, right, just for the sake of your staff, for your nurses, for everyone's sanity, the trainees, it's good to have an approach. So I'm going to walk you through, again, some of the basics. So why is ICP an issue? Because the good Lord, in her insight, gave us a skull. So the skull's hard, protects our brain. These are the normal contents that we see in the skull, and that's all well and good. But the problem is when there's too much volume in that limited space. Remember that you measure ICP either millimeters of mercury, like with the bedside pressure transducer, the upper limit of normal is 15, and that's about the equivalent in terms of 20 centimeters of water, which is what we're measuring when we do the spinal tap. So what causes increased ICP? Anything that increases intracranial volume. A new mass lesion, too much CSF, a swollen and engorged brain, or when the brain tissue itself increases in volume. Most often we see through various forms of infarction or ischemia. How do you lower ICP? Answer is anything that you can do to reduce intracranial volume. Anything that lowers ICP has to be understood as something that reduces intracranial volume. We can call our buddies, the neurosurgeons, and remove the mass. We can drain the CSF. We can reduce cerebral blood volume, first with hyperventilation, and then sometimes more profoundly with barbiturates or hypothermia, right? Because how are those barbs and hypothermia lowering ICP? You think it through. It's got to be profound metabolic reduction coupled with reductions in flow and cerebral blood volume. And then you can dehydrate swollen brain with bolus osmotherapy. So you've seen this a million times, but again, just a reminder that when you're in the non-compliant part of the pressure volume curve, as shown here, the waveform itself on the monitor is a crucial piece of information. Right? In compliant states, as the brain pulsates, you have a small pulse pressure. That little surge in cerebral blood volume is easily accommodated. In non-compliant states, when you're running out of room, the pulse pressure of the ICP waveform goes up. It can be as much as 20 millimeters of mercury itself. And at the same time, the shape of the waveform changes. A normal waveform on top, that first percussion P1 peak is higher in amplitude than P2. When the intracranial system becomes non-compliant, P2 becomes higher than P1. In effect, there's a kind of a pressure stacking effect, right? The left ventricle pumps out, right? And then the aortic valve shuts right? And then there's kind of downstream pressure waves that sort of stack up in that tightened, pressurized, non-compliant intracranial vault. You just saw the slide. We all understand regular autoregulation. But the point is that in states of normal compliance, your blood pressure, your MAP, is not going to affect your intracranial pressure. However, in states of reduced intracranial compliance, the blood pressure itself can influence your ICP. In other words, there's an optimized MAP or CPP that can help get your ICP down. Why? It works like this, right? In some conditions, like over here, right? You've run out of room, so you're vasodilating as your pressure drops, right? But that increased CBV cannot be accommodated, so it drives intracranial pressure up. That's vasodilatory cascade physiology. That is what plateau waves are. So one of the key treatments is to get that pressure up. Then the vasodilation relaxes. On the other hand, in states of extreme hypertension, the high blood pressure can passively vasodilate the delicate cerebral circulation in that way. In these states, right, if you've got a high ICP, high MAP, and high CPP, you want to lower the MAP and get down to there. If you've heard about the lung protocol, right, these are the guys that think that almost always, or practically always, the problem is this. So they advise you want to get the pressures down, you want to get brain metabolism down, you go for the low CPPs and that type of thing. At one point, they even advise for vasoconstriction, right? And when you hear the Rosberg principle, that's this one. The fact of the matter is that both kinds of situations can exist. Some people have one type of physiology, some have the other. I've seen one patient go from one type of physiology and a few days later the other. The beauty of multimodality monitoring is that it demonstrates how this works, that this is real. This curve was drawn based on theoretical concepts only before we ever did multimodality monitoring. Now here's a real patient. Here's 24 hours of data. Here's his ICP against his MAP. You see? That's that. Here's another patient. Here's his ICP against his MAP. Right? Higher the MAP, driving the ICP up. That's that. So these are real concepts. Okay. Who needs an ICP monitor? My feeling, and again, because most of the guidelines are in trauma, but for me, irrespective of how you got into the coma, so it could be an ICH, it could be an SAH, right? What sinus thrombosis, some weird thing, Lord knows, right? Full hepatic failure. One, dude's in a coma. And where you cut that off is, I think, murky. That's not so important. They're not coming in following and localizing. That's often enough, right? Remember, if you're that bad enough, you have your airway protected and you're being sedated, then that means you want to have the monitor because you're losing the sensitivity and you can only do intermittent assessments. Two, in addition to the coma, imaging raises concern for increased intracranial volume. Shifting of basal cisterns, mass lesions. You look at that and say, I'm worried. Yeah, I'm worried. 3, aggressive critical care is indicated, right? And that's basically it. Okay, so we have the Grace Dr. Chestnut here, and so we've had a lot of discussion about the best trip trial, how it's really comparing to strategies. It doesn't prove that ICP monitoring doesn't work. I just want to feature in the Q&A, it'd be interesting to get Dr. Marshall's comments on this. But when I looked at the paper, I saw this, right? And to me, what I find fascinating is that at 14 days, there's an absolutely 10% difference. Mortality was 30% in the no monitoring group and only 20%, right, in the monitoring group. And then over time, you see these lines reapproximate each other. My interpretation was, unfortunately, there's really not a lot of rehab in Bolivia and these other areas of South America where this study was done. So these extra guys that are still alive at 2 weeks, they're the sickest of the sick. They've cheated death, right? They're the guys that are all getting tracing pegs, and you need a lot of support to carry through. So that's the concept of, developing countries versus, more high-tech environments like some of the places where we work. ICP treatment thresholds we spoke a lot about as well, and as we said in Crossfire yesterday, we need to rethink this 20 thing. And I think there's uncertainty in the community about how to best approach this, but a lot of people thinking about this, I think, is going to help us get to better ways. Now, when I think about ICP, I think of it now in terms of tier 1, 2, and 3. So tier 1 is setting the table, right? So like when you know people are going to come over, even before they come, there's certain things, the plates, the candles, and everything. So this is just the basic stuff. Head elevation, no hypotonic fluids, right? You're controlling the airway, you're going for normocapnia. These are the emergency steps that I've got here, the ED. Head up, bolus of mannitol usually, and that type of thing. Okay, let's talk about algorithms. So this was one of the original algorithms that came to the Brain Trauma Foundation. I remember seeing it when I first got a slide deck many years ago. I looked at it, and let's face it, I'm a neurologist, but I went into critical care for a reason, because I'm sort of a dumbass. And this made my brain hurt. It reminded me of that neuroanatomy wiring with the basal ganglia. Remember that? With the subthalamic nucleus hooking back into the substantia nigra, and the globus pallidus, and it made me feel like this guy, and it made my brain hurt. So I needed something simple. Simple for me, simple for the people I work with. So this is a history lesson now. So we came up with this, and you'll see other things that look like staircases. Maybe the steps aren't exactly in the same order, but I was really interested when I started to see other staircases for ICP. But here is the idea. In the old days, okay, patient number 1, to start with, right? The first thing you think is, the definitive thing, is surgical intervention. You begin with that, so if that guy in the ear needs to go to the OR, they do. And that'll solve the problem, right? Before they get to the unit. And remember that as you step up, right, after a certain point, right, you can always pull the ultimate trigger. Theoretically, the ultimate trigger, take off the money. That ought to solve the ICP problem. Now, what it does to outcomes, another issue. Let's say that you've got a ventricular catheter, ventricular collapse. Okay, nurse calls you, ICP's 40. You go see the guy. He's wild. He's thrashing around, right? You sedate him. So sedation is a cornerstone for controlling ICP, right? When in that guy I'm describing, intrathoracic pressures are off the wall. That's largely what's causing jugular venous back pressure and making ICP go up. Let's say his lining is uncomfortable, lining bad, ICP still high. For me, the next thing that I look at is CPP optimization. Because if his ICP is high and his CPP is 35 or 40, I gotta fix that next. And if his ICP is 40 and his CPP is 110, I'm gonna think about fixing that next. Often our guys just have an order, maintain CPP greater than or equal to 15 or 16. But, again, you can start to look and individualize the physiology. Let's say the CPP is 65. The ICP is 40, 45, going up. So then the next steps that almost always actually occur together in tandem, bolus osmotherapy and controlled hyperventilation. So notice I put hyperventilation a little bit later in the algorithm. So I want a PCO2 around 38, 40 to start. And theoretically, the reason why is that the effects can wear off. Right? Eventually, there's equilibration of acid base and that vasoconstriction that you initially get reactolosis kind of wears off, right? Although I will tell you not always. And that certain types of brain engorgement states where increased CVV and hyperemia and vasodilation are the primary driving cause of the problem, early hyperventilation can be very effective and it can work in a very sustained way for days and days. And then, we're at medically refractory ICP. And for years, right, I was taught you put them on the pentabar, and then hypothermia was the weird thing. It was the new thing, and we just started to do it. Over the years, we modified this in 2009, and we said we're getting rid of pentabar, we're just going to do hypothermia. And so that's basically the way we practice. We were just calling people, and then, right, if things get bad enough, and the intensivists are doing all this, at a certain point, we'd be like, are we going to do the heavy crayons? And that's basically how the practice would go. So, in rethinking this algorithm, I rethought it a little bit, and this is yet to be published, and so it's the same idea, right, of stepping up. Because the first cure I mentioned, that's just basic head elevation fluid, seizure prophylaxis, and food control, okay? So you still run up these steps. And the point is to, forgive me here, the point is to not skip a step. So you don't start giving mannitol, expecting that to work, but the problem is that a CPP is 35. You're going to take care of all this together. But it's a way to organize your priorities. And then the idea is there's a lot of variability, so that once you step up to certain things, you're not right, then you've got other options and you can advance as needed, right? So you don't have to, there's no real set way to do that, and you can individualize your interventions, right, based on what you do in your unit, what you've got experience with, right? So let's say you're stepping up, you're already failing, and you're giving repeated dose of hypertonic, right? Well, you can use multimodality to really fine-tune and optimize the CPP. You could paralyze at that point, push osms up above 320 to 340 or 360, it still works, etc. You could try CAM or something like that, right? So that's the algorithm, but now I think in light of the Eurofirm study, I really do have to say that I'm personally not going to be that interested in using hypothermia as a weapon anymore, not given that data that we'll talk about. So I think I got a couple minutes left, so I just, a few nuances about the different steps I just want to show you again. DECRA, right, so we went over what it showed. Very early on, right, at the first line of ICP, no reduction in mortality, even though it lowers the ICP, and more disability, as it's demonstrated here. It's an unconventional way to show this, right? But bottom line, more dead and disabled people here, right, compared to standard of care. My theory about why this happens is that when you open the skull, you distort normal anatomy. The swollen tissues become more swollen, and there's a lot of hydrocephalus, quite a bit. And that hydrocephalus, right, if in young guys that were early on, that's probably a large driver of hydrocephalus and the other baggage that happens anatomically to a heavy craniectomized person may explain that extra disability. So it could save your life, but you really got to be careful. In terms of sedation, somebody asked me yesterday, I like cocktails. And I'm not talking about old fashions or Manhattans. I like combinations of sedatives. And so I'm always thinking pain first, so I like the fentanyl or the remifentanil, and then add on based on what the scenario is. If it's seizure guy or an alcohol guy, I'm liking them to death. There's a lot of dysautonomia, paroxysmal sympathetic, I'm liking the dexmedetomidine. If I really want them stone cold RAS -4, right, then I'm liking the propofol. Just a bit about bars. I don't like bars. I've stopped using pentobarbital. Obviously, a lot of smart people here still use them and a lot of experience. Do understand that despite some of these ancient studies showing some benefit uncontrolled, Cochrane says there's no evidence that it has any benefit. And my personal experience is that when you put someone on penobar, it puts them in a coma like forever, and it increases their risk of all kinds of complications, and they're completely myopathic at the end of it, etc. So that's my bias. This one, I just want to take one extra few seconds in case you haven't seen it. I talked about CPP optimization before, right? This is where the concept comes from. I call this slide, look ma, no mannitol, right? So here's a guy, his ICP's looking pretty good, right? It's low here. And you see CPP's high, like 90. And as ICP goes up to 40, that's a plateau wave. The CPP goes down to 70, which ought to be okay, right? But this is an ICH. And then I start dopamine, raise the MAP, raise the CPP, vasoconstriction, reversal of that vasodilation, bang. Look, ma, no mannitol. In terms of osmotherapy, my only comment is I don't like continuous infusions of 2 and 3%. So you'll hear me, I talk about using bolus osmotherapy. I believe that's the way it should be used because the secretion of that acute osmotic gradient that leads to the water shift, leads to the dehydration, leads to the clearance of the free water. So whether you like the hypertonics, which are better at raising the MAP, or mannitol, which is better in shock states or fluid overload states, it looks like they kind of work about the same, and there's been some enthusiasm, as we heard yesterday, to maybe a study comparing basically going all the way with one versus the other interventions. And I'm kind of running out of time, so I guess I just want to end with, I'm just going to end with this slide. I showed you this before. I think hypothermia is off the map. And so we really did hit a very interesting conundrum. You know, if you're really losing the battle and you're starting to paint yourself into the corner of ICP checkmate, and I have lost young people this way, right? Where effectively we took hemicraniectomy off the table, and I've lost people, you know, where you get that sort of rebound effect in the osmotherapy, or osmosis 380, or hypothermia, and every time you try to back off, right? That type of thing. So my personal bias is for doing craniectomy. As we know, there is this trial called Impact ICP. The results will be out soon, and that's the study that will really tell us more definitively if that's the way to go. That's a trial of looking at pulling the trigger on later craniectomy after some number of hours and hours of failure of medical therapy. Thank you very much.